All right, so the final stretch here, this is the CMPP final. So we have 7 PowerPoints to go through. This is all the new content. Almost every other question on this final is going to be on this. We have 100 questions. Let's see if we can find them all. All right, so I did try this chart here of like all the different topics we're going to go over. I didn't finish it, but if you find it helpful, here's kind of a lot of things lined up. I also have this here, this kind of guide to antibiotics. There's a good amount on this content, and we're going to need to know these for old content as well. So I have all of these here, and we can kind of reference that as we go. There's also quite a few med lists, which are definitely showing up as exam questions a lot, like what medications cause diarrhea versus C. diff versus an ileus versus constipation. I think the one big interesting comparison was between ileus and constipation. I was getting these confused. They share 3 opioids, antacids, and then anticholinergics, but we get into a lot more detail with anticholinergics for constipation. And we kind of like go off brand there a little bit and talk about like scopolamine, the anti-nausea medicine, and like Bentyl and stuff. I think a big one there is going to be the non-dihydropyridine. So it's like, what are verapamil and diltiazem doing in a GI lecture? So she even gave us a mnemonic for this: no do poop. So know that for constipation. She wants us to know these as well, the anticholinergics. So Benadryl, over-the-counter cough and cold, anti-nausea, and then like Bentyl. So definitely going to be a couple of questions on that. All right, so the first topic we have here is acute diarrheal illness. So diarrhea is going to be defined as those loose watery stools at least 3 times in a day. All right. And it can turn into something called invasive diarrhea or dysentery. With that, you're going to have like visible blood or mucus, and you can get a fever and some pain as well. Some other classifications here. So, you just want to memorize persistent diarrhea is between 2 weeks and a month. So just under a month. So 14 days to like 29 days is persistent. Anything shorter than that, it's just acute. Anything longer than that, so longer than a month, is going to be chronic. All right, in terms of causes of acute diarrhea, there's 3 main buckets. There's viruses. These are the most common. All right, we're going to talk about norovirus and rotavirus later. There's bacteria, and then there's protozoa. We're going to talk about Giardia in terms of protozoa. Okay, in terms of the bacteria, we are going to talk about Salmonella, and we're going to talk about Yersinia, and we're going to talk about Listeria. But in terms of this list here, the ones that can actually cause dysentery are Campylobacter jejuni, Shigella, Shiga toxin-producing E. coli, which is STEC, S-T-E-C. Then over here on the protozoal side, Entamoeba histolytica. So that'd be a great question. What's kind of the big acute diarrheal illness causer, specifically for dysentery? And if it's a protozoa that they're looking for, it's going to be Entamoeba histolytica. So could be a question there. So I do have a little mnemonic here. I think of, Junie from Spy Kids, if you've ever seen that movie. He's going camping, so Campylobacter jejuni. He's throwing a little shindig. So anything with Shigella in it is going to cause dysentery. And he's doing this in a history museum, so you're going to get the histolytica from that. And then everyone gets E. coli, which again, if you know the Shigella, but the STEC, the Shiga producing E. coli. So that's your invasive diarrhea, your dysentery. All right, you can also get diarrhea from food, and there's kind of 3 time frames here. So if you get it relatively quickly, less than 6 hours, it's going to be your Staph aureus. You get that from mayonnaise. You get that from poultry. I don't know. This is mayonnaise an instrument is like a good meme from SpongeBob. Think that like SpongeBob is a staff member of like the Krusty Krab, and they're making nasty chicken, mayonnaise, poultry, Staph aureus, whatever. Then there's this one here, Bacillus cereus. This one is going to be from fried rice and reheated leftovers. And if we are getting this diarrhea a little bit later, 8 to 16 hours, it's going to be our Clostridium perfringens. All right, this is going to be from gravy and canned foods. I don't really have any mnemonics for these. And then Salmonella, which we'll talk about in more detail later, it's going to be from eggs and unpeeled fruits and veggies, okay? If it happens longer than this, and this could be a question, If, they had some food and they had diarrhea like a day later or over 16 hours, it's going to be viral or it's going to be some other type of bacteria. Okay. You can also get diarrhea from traveling. So E. coli is going to be the most common, specifically enterotoxigenic E. coli. It's going to start within the first week of traveling. You can also get Giardia, especially from stream water in mountain areas of the US. Also, daycares is a big one for that. And then this vibriosis, so, shellfish from warm coastal water. So I have, while traveling, you want to guard the vibe at all costs. Don't get toxic cold, enterotoxigenic E. coli, but guard the vibe. So Giardia and vibriosis for travelers' diarrhea. You can think of like vibe, like you're, on a warm coastal, on the coast of like Hawaii or something. So, that's where vibe's going to come into play. Okay, so that's going to hit you with 3 or more unformed stools within 24 hours. That's the definition of diarrhea. To treat travelers' diarrhea, it's just going to be supportive fluids, electrolytes. It's mostly going to resolve in a week. If things are a little bit more complicated and this lingers longer than a week or they're immunocompromised, you can use azithromycin. So that's important. Azithromycin is the first line therapy for like this severe traveler's diarrhea. So I think like you want to pop all your zits on your face before you go traveling so that you can like look nice for vacation. So just remember azithromycin for travelers. Okay, there's a laundry list of meds that cause diarrhea. I'm just going to read them all here because these questions pop up a lot. So it's any of your GERD meds. So antacids, H2 blockers, PPIs, they can give you diarrhea. Antidepressants, colchicine, which is for gout, and other NSAIDs. Colchicine really stands out here, so look out for that. Or if they throw ibuprofen or something on there, it's going to cause diarrhea. Metformin, which is kind of a random one. I looked this up. Metformin can actually cause such severe diarrhea that they offer it in a long-acting version, but so that it doesn't cause as much diarrhea, but the long-acting version is expensive. So you'll probably remember that. There you go. ACE inhibitors as well. Biphosphonates like alendronate. This is for osteoporosis. This causes like every GI symptom ever. So if you see that, it's going to cause diarrhea. Magnesium supplementation. That makes sense because when we talk about laxatives a little bit later, the osmotic laxatives like milk of magnesia and I think magnesium citrate are going to be laxatives. So they're going to cause diarrhea. They're going to work a little bit too well. And then this is a big one, antibiotics. It's going to be your cephalosporins and your penicillins, specifically amoxicillin and ampicillin. And you can, these are related, right? So cephalosporin is just a synthetic beta-lactam and penicillin is a beta-lactam. So they kind of go together. So they're going to cause diarrhea. That's just the same here. So if you do get antibiotic causing diarrhea, it's usually mild. Just stop taking the antibiotic. Okay, let's talk about C. diff. So this is a gram-positive rod, although it is anaerobic. I like to think, this is found in the gut, not a lot of air there usually. So they're going to colonize. And this comes into play when your normal gut flora have been disrupted, then the C. diff kind of come out and colonize, all right? And they are transmitted by spores. So that's pretty huge, especially in a hospital setting. Okay, big risk factors here, antibiotics within the previous 2 months. We already talked about this for diarrhea, that penicillins and cephalosporins can cause diarrhea, lump C. diff right into that. But now we're going to add in fluoroquinolones and specifically clindamycin. This was just mentioned in my small group today. I really think that's going to be a question. The way you can think about this, I use these matrices and they just work so well because you can use spatial memory. The diarrhea causers are the 2 on the upper right. The C. diff causers are those as well, and the 2 on the bottom right. So macrolides, specifically clindamycin, the fluoroquinolones, the cephalosporins, and beta-lactam. So that's just the spatial memory of that sticks, and you'll never forget that. All right, zoom back in here. Okay, so yeah, that's how I remember those for C. diff, so for antibiotics. The other thing too, recent hospitalization, but it has to be after 3 days. So somebody just got out of the hospital, it's been like 3 or 4 days, and they have diarrhea, you're going to suspect C. diff. And yeah, I wrote like a little explanation here. It makes sense, right? If they were an inpatient in the hospital and we're like nuking them on all these antibiotics so they don't get sepsis or whatever, their post-op or pre-op, and we gave them antibiotics, you know, you're nuking their gut flora. So C. diff is going to come out. There's a big thing here, the toxins that C. diff release, because C. diff itself is not invasive, like H. pylori is also not invasive, but these are very problematic. They release these toxins. So it's kind of like thing one and thing two from Cat in the Hat. So, you know, the Cat in the Hat is C. diff. He's not really invasive himself, but it's thing one and thing two. Those are going to do the damage. So I just think of like A, E, and BC, like BC, like the time, you know, like before Christ or whatever. So toxin A is enterotoxin. So the A and E come together. And then BC is going to be toxin B. That's your cytotoxin. Okay. Clinical manifestations of C. diff, you're going to get watery diarrhea 10 to 15 times per day. Imagine. That's crazy. So you see that's going to be C. diff. This is big. All right, so huge buzzwords here on an endoscopy: patchy, mild erythema and friability. And then this is a big one also mentioned in small group, pseudomembranous colitis. So both of those, that's going to be C. diff. Definitely questions on that. Can also do stool testing, nucleic acid amplification testing, or NAAT. It's going to be the most common. It's going to look for genes, but it can also overdiagnose. You can also do a GDH, which is a glutamate dehydrogenase, and toxin assays. I have this random thing here. So they're, you know, you're inside, you're in class, they're nuking us outside with this amplified acid. That's nucleic acid amplification testing. Who cares? Stop procrastinating and write your GD toxic essays. So that's your GDH and toxin essays. And then, you know, see the difference. So C. diff. So whatever, if you remember that. Okay, the big thing here, I feel like this is going to be a question. Like you have a patient, they come back positive for C. diff. You want to, you know, obviously stop the inciting antibiotic if they're taking an antibiotic, but you want to start contact precautions for your providers in the hospital. Don't forget like that practical stuff, gown and gloves, wash your hands. You know, hand sanitizer is not going to kill C. diff. You know, if you've worked inpatient, you've definitely seen this before. The antibiotic we do want to start them on is vancomycin, okay? Some big things to worry about here. These are definitely going to be questions. Don't mix them with a class called the aminoglycosides because they can cause ototoxicity and nephrotoxicity. The aminoglycosides that are mentioned are gentamicin, tobramycin, and streptomycin. Do not tunnel into the mycin suffix here. These are not macrolides, okay? I can see them putting a list of all macrolides, but gentamicin, tobramycin, and streptomycin, we haven't really heard about those very often. So they should stick out to you. Those are going to be the ones we don't want to mix with vancomycin because they can cause ototoxicity and nephrotoxicity. Okay, another huge one here. Vanco has to be oral as well as the next med we'll talk about. It has to be oral. IV Vanco does not even cross into the bowel, and it can actually cause something with red man syndrome. If that does happen, we can treat with antihistamine, but just know that it has to be oral. The second C. diff med is going to be fidaxomicin, which is difficid. Diff is right in the name, right? C. diff, difficid. It's right in there. Metronidazole, which is Flagyl, used to be first line. It's no longer considered because of higher rates of failure. Not sure if they'll ask about that, but just know about Vanco and difficid. Okay, acute bacterial diarrhea. We talked about salmonella, and we'll go into more detail here. So there's three, and you want to know the differences and what make these all unique. I color-coded them. So salmonella and Yersinia are pink. Those are your gram negatives. These are all rods. Listeria is going to be gram positive. Okay, salmonella, more specifically non-typhoidal salmonella. This is going to be the leading cause of foodborne disease. Think of all the salmon swimming in the world. Very, very common of foodborne disease. It's going to come from meat. It's going to come from poultry, ground beef, eggs, milk, produce. We mentioned unpeeled vegetables before with salmonella, unpeeled fruits and veggies. Okay, it's going to incubate for half a day to 3 days. And after having the contaminated food, this is big. It's going to enter your macrophages and be able to disseminate to distant sites. It's going to be more common in patients with sickle cell disease. I think about like fishing for salmon with like a Grim Reaper sickle. Treat this with hydration mostly, but there are going to be antibiotics here if it's complicated. It's kind of the same treatment between Salmonella and Yersinia. It's going to be ciprofloxacin or levofloxacin. All right, so we're going to treat this with a fluoroquinolone, which are great for gram negatives. Now, the second line for Salmonella, because this is common in like foodborne disease, and you're probably going to get it if you're traveling as well, is azithromycin. That's going to be your second line, which again is your go-to for traveler's diarrhea. Yeah, I mean, and you know, just to like clarify, Salmonella isn't listed underneath the traveler's diarrhea like slides. I'm just kind of making that connection of azithromycin of kind of what it's used for. So just to clarify there. Now with Yersinia, in terms of meds, again, it's Cipro or Levo, but if it's a child, you want to give them Bactrim. You don't want to give a child a fluoroquinolone for things like it inhibits cartilage growth. There's like tendon rupture. There's a bunch of things there. We'll go over all the antibiotics at the end. All right, let's talk more about Yersinia. So zoom out a bit there. You're going to get this from pigs and undercooked pork. And you can think of the iron pigs. This is Lehigh Valley iron pigs. This is like beautiful that this fits like this. Because if you're in an iron overloaded state, like with hemochromatosis, you're going to be more susceptible to this. The big thing here, Yersinia proliferates in the lymphoid tissue, which can travel to local mesenteric lymph nodes. It can cause pharyngitis because of your lymph tissue up there. It can mimic appendicitis. 100% this is going to be a question. So Yersinia can mimic appendicitis. Your CT is going to show a normal appendix. So there could be a vignette, looks like appendicitis, CT comes back normal. Which one of these is the most common pathogen? It's going to be Yersinia enterocolitica. There is another Yersinia that exists that is not, it's out of scope of this class, but I Googled it. So don't just tunnel into the word Yersinia. Know that it's enterocolitica as well. So you want to diagnose this with a stool culture. It's not part of a routine bacterial study, so you have to ask specifically for this. And again, supportive care, hydration, unless it's complicated or immunocompromised, or you have this hemochromatosis, that's when you want to throw in an antibiotic. Okay, last here for the acute bacterial diarrhea is Listeria. This is positive. This is gram-positive, which is why the treatment is going to be a penicillin. It's going to be ampicillin in the complicated cases. Some huge buzzword things with this. Listeria can cause meningitis and a brain abscess. This is Brain from an old show called Pinky and the Brain. He likes cheese, so Listeria, I didn't mention, comes from soft cheeses, processed meats, hot dogs, sausages. But this is Brain from Pinky and the Brain. Look at the size of his brain. He has meningitis. He has a brain abscess. All right, just lump that together with Listeria. Another huge one here, definitely a question. If you have a pregnant patient with Listeria, they get a flu-like illness, so they want to avoid any soft cheeses. It can actually spread to the placenta, especially in that third trimester, cause fetal death, preterm birth, or an infected baby, okay? A little mnemonic here, lunch moms with shopping lists, and they get amped up. So lunch meat, mom's pregnant, Listeria, and amped up is ampicillin. Okay. I also have this thing. I'm not going to do it, but you can say like yours, like squealing like a pig for Yersinia. So there you go. Yeah, so note the need for fluoroquinolone for our gram negatives. Cipro and Levo are the hallmark, like gram negatives are going to be great. And then the columns are colored by gram. There you go. Okay, here's the other matrix. This is for acute viral and protozoal. Remember, we said viral is more common overall for diarrhea. The most common of those is going to be rotavirus. Okay, this is seasonal. We see it from December and June. So it's like Merry Christmas. You have rotavirus for 6 months. Okay, this is big. It invades and destroys enterocytes and results in shortened and blunted villi. So it kind of looks like celiac disease, right? That's what happens with celiac. So remember that for rotavirus. The interesting thing here with children is their presenting symptom can just be they're irritable. So remember that. Could be rotavirus. You diagnose this with a stool antigen test. There is a vaccine for this. It does cause intussusception, but that's out of scope for this class, but that's from preventative. So I think rota, like a merry-go-round. So you're going to kind of see this more commonly, I think, in kids just overall. And then, just like the kids irritable thing really stood out to me. Oh yeah, it's literally right here. Most common in children. Okay. I think I said rotavirus is the most common overall. It is not. So it is norovirus. It's right in front of me. So just to clarify, rotavirus is most common in children. Norovirus is the most common viral cause of acute diarrheal illness. All right. So I apologize for that. This is going to be from food and water as well. Rotavirus is food and water, but more common. So more common in food and water with norovirus. It's also going to bind to enterocytes, and it's going to induce some mucosal enteritis, cause some inflammation. Vomiting is the predominant symptom here. We're going to diagnose this with something special called a PCR assay for norovirus. So I have this like Norton antivirus thing here to help you remember of like the PCR. You're running this antivirus software because everybody's getting these viruses. Everybody's getting norovirus. Okay, the last thing here, not a virus, it's Giardia. This is a protozoa. You're going to get this, we mentioned before, waterborne in mountain streams. You can also get this. This is a big one, fecal for daycare centers. This can shed asymptomatically for 6 months. So think about that in a daycare setting. It's crazy. You're going to see flatulence and foul-smelling steatorrhea. You're going to pull this ova and parasite lab to diagnose this. We do have some antibiotics here. So Flagyl is going to be our first line, but we can use this unique med called nitazoxanide, which is Alinea. That's a broad-spectrum antiviral and antiparasitic. So I think of like a woman named Alina waving a flag in the color guard. So guard like Giardia, color, it just goes with color guard, but flag for Flagyl, and then Alina sounds like Alinea for this nitazoxanide. All right, so those are your acute and viral protozoal diarrheas. Okay, a workup for acute diarrhea. You look for signs of hypovolemia, obviously like dehydration, things like that. Look for that blood and mucus and fever for dysentery. Recent hospitalization or antibiotic use is going to clue you into some things. And if they're older or immunocompromised, you might want to start some of those antibiotics we talked about. So again, you want to pull the ONP, which is the ova and parasites. It's going to look for your Giardia and your Cryptosporidium. And then you want to do your nucleic acid test or your GDH toxin for C. diff. Okay, first PowerPoint done. Let's talk about ileus. So this is the lack of coordinated peristalsis or a complete cessation of peristalsis. Two most common causes. The first one is going to be post-op. The second one is going to be medication. So definitely a question there. So there is a time frame in terms of the post-op. It has to be after 3 days. If it's between 1 and 3, it's just like a physiologic thing, but it's over day 3. So I have this here. If ileus lasts 1 to 3 days, it's physiologic. Don't even try calling the surgery team. Over day 3, though, like after a nice long weekend, ring, ring. It's now a post-op adynamic ileus or a paralytic ileus. You can blame the surgery team. So there you go. So from like the operation itself, there's surgical stress, there's inflammation. So you have like macrophages, T cells, mast cells, etc. So you have this inflammatory cascade, and that kind of upsets your GI tract and causes the ileus. So I think of it like the peristaltic contractions. They don't like inflammation. They're like, all right, I'm just going to stop moving until all this inflammation goes down. Okay, the 5 A's. So this is 5 meds that cause ileus. So it's anesthesia. That slows you down, right? Antipsychotics, that also slows you down. Anticholinergics, stop parasympathetic activity. Parasympathetic is what moves your GI tract, okay? Antacids, I had to Google this. So they have cations and aluminum in them, which overall inhibit the gut motility. So out of scope, but I looked up why that's the cause. And then opioids is a big one. We'll see that for constipation as well. So again, it slows you down. The big management of an ileus, walk and chew gum, get them up and moving, get them ambulating. The worst thing you can do is just have them sit down, okay? And chewing gum is going to stimulate that gastrocolic reflex. If they have nausea and vomiting, You want to do a no food, nose tube, right? So you want to do NPO and you want to do an NG tube. Obviously, if the med is causing it, just stop the med. And this is a good treatment. I'm sorry. Time is a good treatment. Just wait it out. Okay, I guess to diagnosis, this is important. You're going to shoot an x-ray and just look for gas dilatation in the small bowel and colon. All right. If it's an ileus and not like an obstruction or something, the dilatation will be continuous. So that's actually pretty important. Okay, definitely a question on this. The ileus can evolve into something called Ogilvie syndrome. This is acute ileus with a massive dilation of the cecum greater than 10 centimeters. If it's greater than 12, so if you can fit a dozen eggs through the cecum, then it's actually 100% perforation rate. That's crazy. Okay. And yeah, so it causes acute megacolon. The treatment for this is going to be something called neostigmine. I had to Google this as well. This is a muscle strengthener, and it helps reverse anesthesia. So if that's the cause of this ileus, that's going to help you out there. Okay. And also what can cause this is trauma, infection, a CABG, a total hip replacement. That could totally be in a vignette, a C-section as well. So look out for that. Neostigmine, this is really stupid. I have this huge stick, which can fix your massive cecal dilatation due to Ogilvie. Where can I stick it? Oh, give it to me. Stig it in mine. So neostigmine, Ogilvie. These are getting ridiculous. Okay, an NG tube, also called a Levin tube. Big three things you can do this for. Sample what's in the stomach. Hey, what's in there? Remove things. Remove air, blood, ingested substances, gastric contents. And then you can put things in. You can feed, right? Nutritional support. You can do meds. People who can't eat, they have some kind of like dysphagia, but they still have a functional GI tract. There are contraindications for this. This will 100% be a question. An obstruction, obvious, right? Coanal, which is nose or esophageal atresia, facial trauma, and a basilar skull fracture. Huge one, because you don't want the NG tube to go into the head, to go into the brain. Zenker's diverticulum is a big one. Again, that's that like posterior diverticulum above the upper esophageal sphincter in that triangle, which I totally remember, right? So you don't perforate the zenk. You don't want to do that. Other things like burns and a history of a gastrectomy or a bariatric surgery. If they have a small stomach, if their stomach was stapled or they've had a gastric sleeve or issues, NG tube's probably not a good idea. Aim it back and down, and you can advance it with the help of your patient. They can swallow. You can shoot an x-ray after to make sure it's in place and not in the airway, because a big complication is aspiration. You don't want to give them the NG tube and then start giving them meds or start sucking air out. So keep an eye out on that. Okay, intestinal obstruction. So small bowel obstruction. This is taking a lot longer than I thought. These are most common. The most common causes of these: adhesions or adhesive bands, which are pieces of fibrous tissue. There are pictures of them here. So they can pull two parts of the intestines together or wrap around one part, cause an obstruction. So you're going to get a distension and a buildup of air and fluid proximal to and within the obstructed area. You're going to get bowel wall edema, increased luminal pressure with compromised blood flow, which can cause strangulation. That's the big red flag here. You want to look out for a closed loop obstruction, which can occlude the bowel at 2 points, cause ischemia, and even bowel death. Nausea and vomiting are going to be a big presenting symptom here, more common than a large bowel obstruction. So just think, it's more proximal. So it's going to affect what's up here, your nausea and your vomiting. You're going to get something called obstipation, which is severe and complete constipation. You're going to hear those high-pitched, hyperactive bowel sounds or the tinkling, but only early on. If there's a strangulation, you're not going to hear those. All right. So if you don't hear those sounds and you have a fever, there could be an obstruction and a late obstruction. If there's a high fever as well, you can consider a perforation and contamination. If you palpate a mass, that can indicate this closed loop strangulated small bowel obstruction. So look out for all of that. All right. Run a CBC, look for leukocytosis. So look for, infection. And then there's like a two-step imaging. You can do an abdominal x-ray first. You can do it bedside. It's going to be quick. It's going to show you if there's free air or perforation. And then, again, look for that dilatation of the air proximal to that transition point. And then step 2, when you have a little bit more time and you've ruled out this perforation, send them over to CAT scan, give them that IV NPO contrast, and you're going to be able to detect that transition point. So where is this obstruction? Gastrographin is the water-soluble contrast that you're going to use. Okay, when you do your CT, if you're looking for strangulation, these are the big red flags. Reduced bowel wall enhancement. Okay, so a weaker wall is what I like to think of there if the enhancement's reduced. That closed loop mechanism, which can, stricture it in 2 different places, and then diffuse mesenteric haziness. If you see any of that, it's going to be strangulation and they have to go to surgery. Okay, large bowel obstruction. These are less common. They can be the initial presenting symptom of colon cancer. And you can get what's called a volvulus, which is simply a twisting of the bowel around itself. It's the most common. It doesn't sound benign, but apparently it is. It's the most common benign cause of colorectal obstruction and sigmoid volvulus. This was not, I think this picture was, but not the description, but you can get something called a coffee bean sign. If you see that on a film, it's a sigmoid volvulus, okay? Like we mentioned before, there's less nausea and vomiting and more distension in a large bowel obstruction versus a small bowel obstruction. Management for an LBO is an NG2 for decompression, especially if they have nausea and vomiting. Consult surgery. And we can decompress if they have a sigmoid volvulus via a sigmoidoscopy. There was also this, which was a picture. If you see feculent material in your vomit, then it's a it's a small bowel obstruction, but it's a low distal small bowel obstruction. So I could see that being a question. Okay. Ischemic conditions of the bowel. This is a masterclass on comparison. It's mesenteric ischemia versus ischemic colitis. So again, I use these tables here, and I just dump all the mesenteric ischemia into the blue left side, all the ischemic colitis stuff on the right side. When all the buzzwords just present to me, I can actually feel the answer either on the left or on the right. It sounds crazy, but it works every time. So let's focus on everything and push all this stuff onto the blue left side. This is all mesenteric ischemia. Pain out of proportion, poop. Huge buzzword. There's a free question right there, okay? You can get bowel infarction, sepsis, or straight up death. Huge risk factor, AFib, also mentioned in small group today. That's a question. So look for your AFib patient and pain out of proportion. It's mesenteric ischemia. The 3 big mechanisms here are vasospasm. I'm getting excited now. Vasospasm, hypoperfusion, and occlusion. Okay. Kind of within, now there is acute mesenteric ischemia. There is chronic mesenteric ischemia. There's 3 ways you can get acute mesenteric ischemia. One is arterial occlusion, okay? 85 to 90% of the time, it's going to be arterial. It's going to be in the SMA, and it's usually from a dislodged thrombus from left heart chambers or valves. So AFib, okay? Poor prognosis here. I think most of these do, but poor prognosis. You can have a venous occlusion. Only happens in 5%. It's going to be the corresponding vein, so it's going to be the SMV. You're going to see this more in younger patients in some sort of hypercoagulable state. So like portal hypertension, pancreatitis, contraceptives, I think is a big one. Cancer, of course, and then some type of like coagulopathy with a factor 5 or an antithrombin deficiency. The third one, which I think is really interesting, it's non-occlusive. So this is it's not from an occlusion. It's actually called non-occlusive mesenteric ischemia, but it results from vasospasm or vasoconstriction. You can get this with cocaine, sepsis, or shock. This one has a very poor prognosis. So you can look out for fever, tachycardia, leukocytosis, peritonitis. If you see any of that, you want to send them right to the OR, actually. Gold standard for imaging here is a CT mesenteric angiography. So we want to look for this occlusion. We want to avoid vasoconstrictors. We want to put them on anticoagulation. So it's kind of like they're having an MI, right? And you're going to need a surgical consult for a lap embolectomy to look for dead bowel to take out. This can also be chronic mesenteric ischemia, which has a pseudonym, intestinal angina. This is going to be episodic or constant, okay, hypoperfusion. It's more common in females over 60 with a history of smoking and vascular disease, and it can lead to acute mesenteric ischemia. So interesting. The chronic one can actually lead to the acute, more like life-threatening condition, okay? Things to look out on a vignette are postprandial abdominal pain. So, you know, it's this versus like an ulcer. And then there's this thing called food fear. So you've seen a vignette, you know, I'm almost afraid to eat because of this pain out of proportion. You can look for weight loss because they're not eating as much. And then you can also, this could come up to, you can treat this with a percutaneous transluminal angioplasty. So balloon this occlusion out. So everything I just said, it's on the left. This is mesenteric ischemia. Now let's put everything on the right and talk about ischemic colitis. Pseudonym here is watershed colitis because you're going to see it in those watershed areas where blood flow transfers from one vessel to the other. So splenic flexure, and then you're also going to see this in the sigmoid colon as well. This is typically a transient problem without a gross vascular occlusion, okay? Ischemic colitis, it's the most common form of GI ischemia. Think about how many waterways are in the US. Very common to live near a waterway. Does that make sense? I don't know, but you'll probably remember it. So this is most common. All right. So this can happen. There's an issue here. So if there is, what happens here is there's like some type of hypoperfusion. So some type of event where there's not a lot of blood flow. And then we fix that problem. All the blood rushes back, and then we can actually get necrosis. I think it has something to do with like too much oxygen then becomes like acidic and necrotic. So that's kind of an interesting pathology here. Some risks: over 65, female, again, COPD, vascular disease. So similar risk factors, especially specific to that chronic mesenteric ischemia. Okay. Already mentioned the watershed areas there. This marginal artery is coming up again, a specific factor up in that splenic flexure area, because 50% of the population has a poorly developed one, 5% have it incomplete as well. So you're going to get some ischemia in that watershed area. The big clinical presentation here is an acute onset of abdominal pain with the urge to defecate. Now, the pain, like the painful hematochezia, bright red blood, is like the huge vignette here, especially when we're doing this versus diverticular bleeding, which is going to be painless. What I thought was interesting here, though, is that you can get the hematochezia not right away. It can actually develop within 24 hours. So I thought that was pretty interesting. The treatment for this versus like calling surgery and like freaking out on the left here is just like bowel rest and observe. So this is like, you know, it's very common, not very common, but it's the most common form of GI ischemia. And the treatment is just to kind of chill and relax and kind of wait for it to pass. All right, PowerPoint 3. Intussusception, also mentioned in small group today. This is the most common abdominal emergency in early childhood. Every kid this year, look at space behind me. Every kid this year is getting a telescope. It's the most common abdominal emergency in early childhood. There's one question right there. Most cases are simply idiopathic, okay? The most common location for this, and again, this is that telescoping of one part of the valve into another where it's not supposed to belong. So the most common location here is going to be the ileocecal junction, where the small bowel meets the large bowel. There's something called viral gastroenteritis season. I should have Googled this, but it is a peak incidence of intussusception. I would guess it's like in the winter, but I'm not sure. Should I Google it? All right, let me Google it. Viral gastroenteritis season. Fall and winter, let's go, baby. Okay. And it's actually related to not rotavirus, which was like December. but it mentions norovirus as well. All right, anyway, that's weeds. The presentation of this is going to be sudden severe abdominal pain, cramping. Okay, it's going to be episodic, so not constant. That actually was mentioned today, so look out for that. However, the pain is progressive, so these episodes are getting worse and worse and worse, like a bad Netflix show. Look for inconsolable crying with the kids. Buzzword city over here. 70% are going to have current jelly stool and a sausage-shaped mass in the right side of the abdomen. So on the set of Inception, which sounds like intussusception, Leo DiCaprio, he was robbed for the Oscar win that year. He insisted on being fed jelly and sausages. So intussusception, current jelly, sausage-shaped mass. There you go. Okay, you're not going to see this on an X-ray, but you can evaluate for air. Ultrasound is a method of choice, especially for kids. You know, we don't want to give them unneeded radiation. The treatment here is kind of interesting. It's a non-operative reduction using a hydrostatic or pneumatic pressure enema. And I think there's like saline involved in that. So that's pretty interesting. And post-op, you can get an expected fever. Sure. Okay, appendicitis. Where the Taeniae coli converge, the vermiform appendix begins. The classic presentation is the periumbilical pain, you know, that then travels to McBurney's point, which is the third from the ACIS to the umbilicus. You can get dysuria, polyuria with a pelvic location of the appendix. That's interesting. So if you have a patient presenting with this classic presentation and they say they're having dysuria, the question is going to say, what is the most likely location of the appendix? It's going to be pelvic. That's where all of your GU stuff is, in the pelvis, so it makes sense. Okay, the initial inflammation of the appendiceal wall exists. It just happens, right? But why? Something called fecaliths. These are hard, poopy fecal masses, and they're more common in adults, okay? There's also these calculi, which are appendicoliths. And then you have lymphoid hyperplasia, most common in teens. So I don't know, just think like kids have really big lymph nodes and they're still growing and whatever. So that's going to be most common in your younger population, in your teens. Older people are more common to have like constipation and hard fecal masses. So that's going to be more common in adults. So after this inflammation, we have an obstruction, which leads to ischemia, which leads to perforation, which can either lead to an abscess or peritonitis. You don't want either of those. So the engorgements, this is kind of interesting, stimulates visceral nerves T8 to T10, that's what results in that classic periumbilical, you know, that poorly localized, or I guess that's more referred, whatever. T8 to T10 is going to be that visceral pain until it gets to the somatic area in the right lower quadrant. Okay. If they have tenderness of the right adnexa with the right lower, or when the right lower quadrant is palpated, they have a retrocecal appendix. So right adnexa is going to be retrocecal. Adnexa kind of sounds like a retro, like Alexa. So retrocecal, there you go. All right, we do have the special tests. I mean, we've gone over these so many times. The psoas sign, that second technique, is actually mentioned here with passive extension. So if you see that, it's going to be retrocecal. Obturator is really not the most accurate. I think that's the one that's not great in older people as well. And, oh, this could totally be a question. So white blood cells, so if they are, I guess, 14.5 or less, it's acute appendicitis. If it's 17.1, it's gangrenous. And if it's 17.9, it's going to be perforated. Gold standard here is going to be a CT scan of the abdomen and pelvis, because we don't know where it is, with IV and PO contrast. So not ultrasound. That was something that I was like, hey, I wonder if like ultrasound is it's not. It's a CT scan. So just remember that. Ultrasound isn't the answer for everything. Okay, when you get your CT, you want to look for an enlarged diameter, so greater than 6 millimeters. The appendiceal wall thickening greater than 2 with wall enhancement. You're going to see fat stranding. You're going to see those appendicoliths, calculi that we talked about, and an absence of air in the lumen. Okay, now you can do an ultrasound, right? So if your patient has kidney failure and they can't tolerate the contrast, or they're just not stable, or it's a kid and you don't want to throw them into a CAT scan machine, you can do an ultrasound. And the one indicator there is going to be a diameter greater than 6. And your other indicator is going to be this target sign, and that's going to result from a fluid-filled lumen. So target sign, huge buzzword. You're most likely to see that on an ultrasound for appendicitis. Okay, how do we treat this? It's called a lap-appy, right? A laparoscopic appendectomy. So we're going to take it out. You want to prophylactically start antibiotics before surgery. Oh, I have a crazy mnemonic for this. If it's acute and non-perforated, so it's just a simple procedure, you're going to use cefazolin and cef. So that's a cephalosporin, I believe, a first generation, and then a metronidazole flagyl for your, that's anaerobic, right? I should probably know that. Pretty sure. Yeah. Flagyl is the one that's absorbed by anaerobic bacteria and broken down, and then the byproduct kills bacteria. So there you go. Just don't forget the antabuse reaction and the with alcohol and the metallic taste. Okay, it's gonna be like a 3-hour video. All right, so if it's more complicated, if it's not, if it's maybe it is perforated, you're gonna bust out the big guns and you're gonna use your piperacillin tazobactam. Okay, this is Zosyn. Remember, Unison and Zosyn are those like really expensive ones, but they cover everything: gram negative, gram positive, aerobes, anaerobes. These things are great. Okay. I have some other detail there about the first gen. All right. So you're doing a lap-appy, your most classic, it's really like your most classic general surgery procedure in existence, but it's 1876 and your surgeon needs a flagon, which is like an old school container for booze. This guy has one here. He needs a flagon before he operates. So flag and cef. So it's flagyl and cef. It's also called Met-Cef because if you use the other names for those meds, metronidazole, which is flagyl, and cefazolin, which is Ancef, okay? But if it's complicated, he needs to fast forward to the future and use the fancy meds, and it's Dunzo. So Zo is Zosyn. So that's your piperacillin tazobactam. Okay. I'm going to skip over this because I just took those in class. All right, let's talk about diverticular disease. A diverticulum is simply a sac-like protrusion in the colon wall, and a diverticulosis is simply the presence of a diverticula, okay? Now, this can get complicated either into diverticulitis, diverticular bleeding, or something called SCAD, which I don't think we get into, so we won't talk about it. This is going to be a question. So how much fiber should somebody have? So 14 grams per 1,000 calories. For like an active adult, it's going to be like 25 to 35 a day. And you want them to quit smoking as well. Most patients in the developed world have left-sided diverticulosis, primarily sigmoid. Cool. Okay. So you have a diverticulum, which means you have diverticulosis. And if it becomes eroded, inflamed, or micro or macroscopically perforated, you now have diverticulitis. Despite all of that, most of these are going to be uncomplicated, but it can recur, and each recurrence is not, each subsequent episode does not increase the risk of complications. That's a pretty interesting nuance here. Okay. Now, we can get complications if any of these happen. And actually, we'll talk about this in a second because I kind of have like a little mnemonic for it. It's FOPA. So FOPA is going to be a fistula, an obstruction, a perforation, or an abscess. Specifically, we talk about a macroscopic perforation. Macro, large, not good. All right, clinical presentation for uncomplicated diverticulitis. Hematochezia is a rare presentation. Left lower quadrant pain because sigmoid is most common. You can palpate a mass here due to pericolonic inflammation or an abscess. If you do have tenderness or a mass on rectal examination, it's a sigmoid abscess, or at least suggestive of one, okay? Red flags, if the fever isn't responding to antibiotics, oh yeah, you can get a fever. Perforation signs, abdomen's distended and tender to just light palpation, diffuse guarding rigidity, rebound tenderness. Those are never good. Absent bowel sounds. We have these two fistulas. So if it's colovesical and the colon is connecting to the bladder, you'll see air bubbles in your urine. You'll see fecal matter, fecal urea, and you'll just have trouble urinating. If it's colovaginal, I think everybody knows what happens with this one. Feces or gas will escape through the vagina. Okay, imaging here is going to be a CT scan with oral and IV contrast. Do not do a colonoscopy. Do not do a barium enema. However, she mentioned this like 3 times. You want to do a colonoscopy like 6 to 8 weeks after the resolution. So after the itis is gone from the diverticula and there's no more inflammation, you can go back and look and just like see what's going on and look for complications, whatever. All right, how do we treat this? You have a decision, outpatient versus inpatient. You know, if it's symptomatic but uncomplicated, just do bowel rest, MPO, clear liquids, and antibiotics. We'll talk about those in a second. If you're definitely doing inpatient because you have some type of complication from that FOPA, fistula, obstruction, perforation, abscess, or any of these 8 things, sepsis or immunosuppression, microperfs, fever, abdominal pain, advanced age, intolerant of PA. I mean, you know, it all kind of makes sense. Okay, meds. Oh, geez, there's a lot going on here. All right, let's just go to this. Let's go to this chart and then we'll go back. Okay, so if it's uncomplicated treatment for diverticulitis, you break out your flagship. So flag is Flagyl and CYP is ciprofloxacin. Both of those, okay? It's your flagship. Or like if that doesn't work, or just augment it and bust out your augmentin, which is your amoxicillin and your clavulanate, okay? If it's complicated, if you're an Always Sunny fan, rock, flag, and eagle. Rock is Rocephin. Flag is Flagyl. And eagle, I think of like, you're just like sinning and spending a bunch of money. So you pull out those Unicin and Zosins, those really expensive combos, or you plug in an amp and smoke a pipe. So that'll help you remember the ampicillin, piperacillin part. So again, rock, flag, and eagle is like option 1. That's just your Rocephin, which is ceftriaxone. That's a 3rd-gen antibiotic, and Flagyl. So you have that anaerobic coverage. Or you bust out the big guns, ampicillin, sulbactam, Unicin, or piperacillin, tazobactam, Zosyn. Okay, let me go back here. There are some things for these antibiotics. Again, I'll try to remember to do those at the end. As we continue to treat our diverticulitis patient, you want to do clear liquids, low residue, which is like low fiber, low dairy. You don't want to like upset things. You don't want to make the inflammation worse. Eventually, you are going to move them to that high fiber diet to maintain bowel regularity. Remember, 14 grams per 1,000 calories. They don't get better in 2 to 3 days. Consider a complication, and then do a colonoscopy in 6 to 8 weeks. Don't forget to follow up. All right, we talked about FOPA here. You can get a fistula, but the colovesical is most common. So the bladder one, look out for that. Perforation is pretty rare, but it can happen. And then an abscess. Big thing to suggest an abscess is no improvement in pain or fever within 3 days of the antibiotics. So, you know, kind of makes sense. All right, there is some surgery. Oh yeah, this is really important. There is some surgery here. We can do a laparoscopic primary anastomosis where we just remove the diseased bowel and anastomose the healthy ends together. Or if there's acute diverticulitis with frank perforation, we do something called a Hartmann's procedure. Okay, so again, if there's acute diverticulitis with a frank perforation, this is a life-threatening condition and you need emergent surgery. All right, if we can't do the primary anastomosis, we do a Hartmann's procedure. What this is, you resect the diseased colon, you just get rid of it, you take it out, and you create a colostomy with a rectal stump. So literally your rectum is a stump. It's just sitting in your body. It's not doing anything. Then they reverse the colostomy in 3 months or so. So I don't know if do they connect one end to the other? Do they Were they storing that missing part of, that doesn't make any sense. So I guess they would then do an anastomosis. I don't know. I don't think that's really important, but they reversed the colostomy. It's not a permanent thing. Okay, let's talk about diverticular bleeding. This is actually the most common cause of lower GI bleeding, hematochezia in adults. The most common cause of rectal bleeding in those less than 50, specifically rectal bleeding, is going to be hemorrhoids. All right, the big thing here is going to be the acute onset of painless bright red maroon blood. So your patient was on the toilet, living their life, and they look down the toilet and there's just blood out of nowhere, okay? Because this is painless, it just kind of happens. And blood is a cathartic agent, so we're gonna get this urge to defecate as well. All right, if the bleeding doesn't stop, we can do a nuclear medicine bleeding scan. So that's pretty interesting. All right, Meckel's, and then we're done the third PowerPoint. So we've met Zenker, and now we're going to meet his cousin Meckel. So Meckel's diverticulum, it's the most common congenital anomaly of the GI tract. Do you remember what the most common abdominal emergency is in children? It's intussusception, right? Because they're all getting telescopes for Christmas. I should double check this. Where even was that? Yeah, it's totally intussusception. And do you remember the two big buzzwords that Leo DiCaprio requested on the set of Inception? Jelly and sausage. So current jelly, stool, and sausage-shaped masses. All right, let's go back to Meckel's diverticulum. Okay. Yeah, so there's this thing. So why this actually happens is, again, it's congenital. It's the incomplete obliteration of something called the vitelline duct. This is a long, narrow tube connecting the yolk sac in utero to the midgut lumen. The yolk sac is where an embryo gets early nourishment. There's this rule of twos. I'm not a huge fan with this. Let me see if I can remember. I did just look at some of them. It's 2% of the population. It's male over female 2-to-1. It can be 2 inches, or I think it was said 2 centimeters. It can be within 2 feet of the cecum, and 2 to 4% of the population get complications. Is that everything? Yes. Cool. I'm sure there'll be a question on that. So 25 to a half of all patients with symptoms are going to be less than 10. So look for it in kids. If a child has recurrent intussusception, painless lower GI bleeding, or if they have appendicitis symptoms and they don't have an appendix, then you can look for this. What else might you look for if a patient is getting appendicitis symptoms, but you do a scan? You would do a CAT scan, right? And it's negative for appendicitis. What else could they have? Should be the one that's spreads to the lymphoid, and I believe it should be Yersinia, right? Yeah, that's it. Okay. All right. Never going to finish this video. Okay. So, all right. So how do we diagnose this? We do a Meckel scan. This is a nuclear medicine test using 99M technetium. What we're looking for here is ectopic gastric mucosa. So gastric mucosa where it's not supposed to be. For an adult, we don't do the Meckel scan. We do a mesenteric arteriography. Okay. So nuke med for the kids with the Meckel scan, mesenteric arteriography, which I think is just a CT scan with contrast for adults. So if the Meckel is a source of symptoms, we take it out. There's like these 3 different buckets. So if we found it in a child, we can take it out. If they're less than 50, but I guess older than a child, but it's long or broad, like greater than 2 centimeters, we take it out. If they're old, we don't want to take it out. It's probably too risky. Okay, let's talk chronic bowel disturbances. So constipation, we all have it. We all love it. It's not always benign, as it can include perforation, hemorrhoids, anal fissures, fecal impaction and ulceration, and overflow diarrhea. So the Roman Empire came together. They decided they wanted to define constipation for some reason. So they did that. So we have this thing called the Rome 4 criteria. Let me see if I can recall this as well. It all has to do with 25%. So I've strained during more than 25% of my bowel movements. I've had like solid fecal bowel movements more than 25% of the time. I felt like I've still had to go after I've finished. I felt like something is like obstructing after I'm finished. I've used mechanical means to clear out my bowels. And then the other one is, I think I've gone less than 3 times in a month. Yeah, that's it. So you need what, 2 of these over 3 months? Yes, you need 2 or more of these for at least 3 months to have constipation. Okay. Loose stools can't, oh, and you can't have loose stools. This thing never ends. We can't have loose stools, and we don't have IBS. Okay. All right. The big causes of constipation. First one's dietary. It's not enough fiber or not enough water. The elderly are more susceptible because of their tea and toast. In terms of hydration, you want 3.7 liters for men, 2.7 liters for women. We talked about that fiber. This says 20 to 35. So either it was listed differently on the slides because the other one said 25 to 35. So I'm not sure, but I think 14 for every 1,000 is the important one. Medications can cause this. Opioids is a big one, right? That's going to slow us down. So know what, that Percocet, Vicodin, and fentanyl are opioids. They can also cause opioid-induced constipation. Anticholinergics, and we get a little like out of scope for that a little bit, but Benadryl, over-the-counter cough and cold medications, anti-nausea medications like scopolamine. Don't forget there's like 6 anti-nausea meds. That's the patch you give to somebody if they're on like a cruise ship. And then antispasmodics / anticholinergics like Bentyl. Vitamins, iron and calcium. So I don't know, think about like a big heavy iron in your gut and it's just lodged in there and you're constipated. Calcium, how about like a big gallon jug of milk that's just stuck in your gut and you're constipated? There we go. Antacids. And then, oh, this is a big one, heart meds. There's even a mnemonic, NDP, no do poop. So your non-dihydropyridine calcium channel blockers, and know what those are. It's going to be your verapamil, which is your Verilan, and your diltiazem, which is cardizem, right? And then also diuretics. So look out for like heart meds there. These can cause constipation. Metabolic causes, it's hypothyroidism, hypokalemia, and hypo and hypercalcemia. Hypo and hypercalcemia. There we go. Neurologic issues, spinal cord injury, Parkinson's, either from the disease itself or the meds for Parkinson's, because if they have tremors, you're going to give them something to like slow them down, or a history of a CVA. Malignancy can cause it, and then pregnancy as well, just due to higher progesterone levels. All right, red flags to look for. I mean, pretty obvious ones. Family history of GI malignancy, that's going to be a big one. Overdue for a colonoscopy. So things that could point to some type of malignancy. If they have adenomatous polyps, which we'll talk about a little bit later. Patient education is your big, it's constipation. You don't want to get crazy. Patient education is the big one here. Get them to have fiber in their diet. You can also use a bulk forming laxative like Metamucil. Okay, so there's actually an overwhelming amount of medications for what we're calling chronic bowel disturbances. So let's go through them all. Again, I'm using this matrix of 9, and you just store information. I'm telling you, it's amazing. It works. You store information into corners, into boxes, and I remember almost this entire chart. Okay, bulk forming laxatives. This is going to be Metamucil. It's fiber basically. It holds on to water and provides stool bulk. Make sure you take this with water. Next, you have your stool softeners. I'll see if I can recall some of this. This is going to be your docusate or your Colace. I think of like a thin piece of lace over your hemorrhoids or anal fissures, because that's what this is going to be good for. So these are your stool softeners. All right, your stimulant laxatives. This is going to be your Senecot and your, is it Docalax, which is bisacodiol. And then the big thing here you want to look out for is, I believe, hypokalemia. There you go. So this is going to alter electrolyte transport by the intestinal mucosa. Middle left, this is going to be these are your osmotics. So these are hypertonic. And this is going to be magnesium citrate. It's going to be milk of magnesia. It's going to be Miralax, which is polyethylene glycol. And I think there's a fourth one. Oh, lactulose. So that's going to be your osmotic agent. So hypertonic, which I believe just holds on to water. We'll check that in a second. And the middle one is going to be for disimpaction. These are going to be our enemas. So there is one called, I think it's sodium phosphate. This is our fleets. We also have here our molasses is there as well for disimpaction. What is on the middle right? I don't know, but we'll do bottom left. So bottom left, these are your meds for IBS-C, which is irritable bowel syndrome, constipation. So these spell malt. So the first one is going to be Motegrity. This one is just for CIC, which is chronic idiopathic constipation. The A is going to stand for Amitiza, and this is going to be for, I think it's just for women over 18. I think this is the one Mel G saw on like a rotation. The mechanism for this one is going to be, it's something with chloride channels. That should be enough, right? The L is going to be linaclotide or Linzess. And then the T is going to be Trulance. So they go together because they have this, you don't take them together, but I lump them at the end of that mnemonic because they're both, it's like guanyl cyclic ACE something agonist. That's going to be their big mechanism there. Okay. To the right of that, this is the bottom middle are going to be the IBS-D medication. So it's C and D, it's alphabetical order. These are going to spell quill, but there's just 3 of them. So the first one is, and just the IBS-Cs, A, L, and T can all be used for IBS-C and CIC, chronic idiopathic constipation. That Motegrity is just for CIC. Okay. Quill, so IBS-D. So this is going to be Questran, and that is a bile acid sequester, or N, I think, a prokinetic, but I think the bile acid sequester is the big one there. That's our QI. The I is going to be Imodium. This is important because it is an opioid. Oh, I just remembered the missing box. This is going to be an opioid agonist. So you want to be careful with patients like being dependent on this or abusing this. Okay, QUIL. So the L is going to be Lamotil. This one, I don't remember the exact mechanism here, but this can cause toxic megacolon. So watch out for that. It can also cause, because it's whatever is the generic has atropine in it. This can cause atropinism, which I think it's like tachycardia is a big thing there, like hypertension. But yeah, it can cause toxic megacolon as well. We'll go back up to the middle row all the way on the right. That is going to be our Pomoris, which is something opioid receptor antagonist. This is going to be specifically for opioid-induced constipation. And this is, it's Relistor and it's Movantik. So Relistor and Movantik, those are our 2 Pomoras. Oh, and then the bottom right is just going to be our miscellaneous ones. So the number 1 medication for pain, for like abdominal pain for all of this is going to be Bentyl or dicyclamine. This is our anticholinergic, antispasmodic. And then the last med that's mentioned here is amitriptyline Elavil. This is a tricyclic antidepressant that's going to help with all of this. I think that's everything. I mean, there's other little details here, but that's everything. I'm telling you, you know, this works really well. So I did miss an enema called glycerin bisacodyl. So bisacodyl is mentioned in two places, those stimulant laxatives on the upper right, and then the enemas and suppositories. I don't think I mentioned that Senna and Dulcolax are stimulants. So those are their class. But I think that's pretty much everything for the meds. Cool. All right, let's move on. So irritable bowel syndrome, the definition of this: chronic abdominal pain, altered bowel habits. We'll talk about irritable bowel disease later. So irritable bowel syndrome can account for up to half of all GI referrals after the common cold URI. This is the second most common cause of absenteeism. That's crazy. I should bold that. That's just like good to know in general. Now there's two flavors here. Part of my wording: IBS constipation predominant, IBS-C, and IBS diarrhea predominant. We already went through all the meds for all of those. The exact pathology on here isn't clear, but there's kind of four things we think contribute to this: abnormal motor patterns, the visceral hypersensitivity, the intestinal inflammation, and then like psychologic things as well. Patients with IBS are just in general stressed out. They have increased anxiety, depression, phobias. Intestinal inflammation, we're going to see an increased number of lymphocytes. Visceral hypersensitivity, we're going to see hypersensitivity, hyperresponsiveness. Oh, this is like they feel bloated earlier than somebody normally would. That's what they mean by visceral hypersensitivity. And then prolonged transit time, which is more common in patients with IBS-C, slower moving, or increased frequency and irregularity of contractions. So fast transit time, which is going to be IBS-D. So that makes sense. All right, red flags for this, especially if they have chronic abdominal pain: weight loss, obviously, malnutrition, progressive pain that does not follow a pattern. I think you're going to see a lot of, this is very pattern heavy for IBS. Look for altered bowel habits. I mean, these are kind of like self-explanatory. Bristol stool chart, your 1 and 2 is going to be for your constipation. Your 6 and 7 is going to be for your diarrhea. It can be mixed, where you get a little bit of both, or just unclassified, which meets no criteria. The Rome criteria came together again and wanted to talk about IBS. So you just need any two of these 1 day per week in the last 3 months. So abdominal pain related to defecation, a change in your frequency, or a change in your form. So if every Sunday, 1 day per week, you have abdominal pain and poop yourself and notice your poop looks different during waking hours during the months of August, September, and October, so 3 months, and it's November, then you have IBS. So form, frequency, defecation. Then there are other symptoms that aren't part of Rome. I mean, I'm not going to go through all those. I think that's kind of weedsy. You can run different labs. So celiac to rule that out. Cultures, look for bacteria. CRP sed rate, and we'll talk about fecal calprotectin. That's going to be for our ulcerative colitis and for our Crohn's. So that's why, yeah, for IBD. I don't know exactly what the CRP sed rate is for, but you can run that as well. There is no known cure of IBS. So when you have it, you just have it. Physical activity is a huge one. So just get up and moving 20 to 60 minutes, 3 to 5 times per week. You're going to see a big improvement in symptoms. Then you can try this thing called the low FODMAP diet. So FODMAPs are osmotic and pull water into the intestinal tract. So, it's going to give you diarrhea, I would assume. So if you try the non-FODMAP diet, things might get better there. Do not give probiotics to the immunosuppressed. I could see that being a question. And remember, they have to come up with 100 questions from this. So as much as I say some of this stuff is weeds, this could totally be a question. You have to get 100 questions from 7 PowerPoints. So there's probably going to be some pretty specific stuff on here. Just So there are meds, because we talked about like 12 of them. So there are meds that we talked about, but remember, they're adjunctive therapy. Diet and lifestyle, this is like for everything in medicine, are going to be the big things you want to change first. Okay, 5, inflammatory bowel disease. So this is ulcerative colitis versus Crohn's disease. And the big path here is a mucosal immune response. So the patient is unable to tolerate their own gut microorganisms. This, again, is a masterclass on compare and contrast. So we're going to dump all of our ulcerative colitis info on the left. We're going to dump all of our Crohn's disease info on the right. And like little silly pictures like this are, they're so unbelievably useful. Okay, let's do ulcerative colitis. And I guess we can compare. Let's do some comparison at first. So ulcerative colitis, slight male predominance. That's why it's colored blue. Crohn's disease, slight female predominance. That's why it's colored purple. You can think about this. Men are generally larger. So you're going to see ulcerative colitis in the colon, in the rectum, in the large intestine. Women are generally smaller. So they're going to get this in the small intestine, namely the ileum. Okay. Colitis, the second letter of colitis is an O. It's a circle. So this is a circumferential issue, this thumb thing, okay? Crohn's, you can think of crow, like croak, is going to skip like a frog. So this is something else with Crohn too. Oh, just Crohn's disease in general. So Crohn, croak like a frog, skip like a frog. This is going to be your skip lesions, okay? The word ulcerative in colitis, I think of like ulcerous, kind of like a serous mucosal membrane. It's going to be a mucosal issue, okay? Crohn, I think of like a crayon drawing a mural. So Crohn, crayon, drawing. Transmural. So this big mural, it's going to be a transmural issue, okay? Smoking, ulcerative colitis. The very first day of class, they asked us all, there's one condition where smoking can make it better. And the answer is ulcerative colitis. We've come full circle. It's crazy. So smoking is not a risk factor. And in fact, stopping smoking can worsen ulcerative colitis. Okay. Smoking is a risk factor for Crohn's disease. This is a board question, and it's definitely going to be a question on Monday. And smoking cessation results in a decreased Crohn's disease flares. Actually, I think it's the only or the biggest modifiable risk factor for Crohn's. Okay. This compare and contrast actually does work. So bloody diarrhea is a hallmark of ulcerative colitis. Think ulcers, blood, right? You do get diarrhea in Crohn's, but it's not usually bloody. You're going to get more nausea and vomiting. So again, the ileum, small intestines, you're going to have more kind of coming out the front. So you can think of nausea and vomiting more associated with Crohn's. Okay. Ulcerative colitis is going to be more gradual and progressive. They didn't not mention that for Crohn's, but the big thing here for ulcerative colitis is that patients are in a hypercoagulable state. I don't know exactly. I mean, colitis, CO again, so coagulable. I guess you can remember that. And then Crohn's disease, you're going to have evidence of malabsorption. So however you want to remember that. Okay, some other huge buzzwords here. We're going to pick up a lot of points. So crypt destructive colitis. If you remember, think of crypt. I have the crypt keeper over here on ulcerative colitis. I just remember he's on the left. It's ulcerative colitis. Done. And the result of that, I guess we can actually talk about what it is. It's just a damage of the mucosal cells. So remember, ulcerative colitis, ulcerous mucous membrane. It's going to be mucosal issues with crypt destructive colitis. Okay. You can get something called ulcerative proctitis. Oh, she said this was an exam question. So pancolitis with ulcerative colitis, this is where it extends proximal to the splenic flexure and involves the cecum. So it's involving more of the entire bowel, because normally ulcerative colitis is just like the rectum and more of the distal colon. But if it's pancolitis, it's going to extend proximally, go all the way to the cecum. If they have pancolitis, they need annual colonoscopies, so we can see the whole colon at 8 years after their diagnosis of pancolitis to assess for dysplasia. So if they're diagnosed, we need to see them in 8 years and see if there's been any cell change. Okay, so big buzzwords for ulcerative colitis. Now, for Crohn's, there is this abnormal overproduction of Th1 and Th17, these specific types of cells. I don't really know how to remember that. Just remember that's on the right here. Big buzzwords. You see cobblestoning and you see granulomas. So I think like an old crone, like, you know, grandmother walking on these cobblestones. An old crone. She's like a grandmother walking on cobblestones. So that'll pick up granulomas for you, and that'll pick up cobblestoning. Okay. More buzzwords. This is like crazy. So you can run a fecal calprotectin for both of these. So if you're looking for, I guess, either or both, just know that fecal calprotectin has to do with irritable bowel disease. Okay. We can get fulminant colitis, toxic megacolon with ulcerative colitis. We can get erythema nodosum with ulcerative colitis as well. So these are going to be tender nodules on the skin. I mean, they kind of look like ulcers, so just ulcerative colitis for that. You can also get something called pyoderma gangrenosum, which is neither gangrenous nor infectious. Okay. And you can use maggots as therapy. So that could be a question as well. So just think about, think about these more. Oh, I'm sorry. That's actually the one that's pictured here, not erythema nodosum. I think it's just like more redness. So that's all going to be involved with ulcerative colitis. Okay. Now, Crohn's, we can use something called the Crohn Disease Activity Index or the Harvey-Bradshaw Index. So I put Sabrina the Teenage Witch. So Harvey's over here with his girlfriend Sabrina on the female side of things in the purple here. This is like a 90s show, so nobody's even seen this. But Harvey was like the love interest from this. So I put him over here. So you hear Harvey Bradshaw, you're going to think Crohn's disease. You can also, and this is because of the transmural involvement, get this fistula formation. So you're going to see that more in Crohn's disease. Okay. You can do a C-reactive protein to look for ulcerative colitis. There's also this P-ANCA. I think she's going to ask a question on this. A positive P-ANCA, you're going to see in ulcerative colitis. A negative, you're going to see with Crohn's. So she said, NC in P-ANCA, whatever this is not Crohn's. So if it's positive, it's ulcerative colitis. All right, ulcerative colitis, you can do a CAT scan with IVPO contrast and a colonoscopy, because again, you want to look for this continuous and circumferential involvement. With Crohn's, you're going to see more of the skip lesions. It is not continuous. And you're usually going to start with a colonoscopy with an ileoscopy. You want to see that ileum. You can do a CT, but it's not specific. Okay. Huge thing here. For ulcerative colitis, a total colectomy can be curative. That's huge for this. And it's a total colectomy. They take out the entire colon. That's crazy. A big complication, though, is a stricture in the rectosigmoid colon. You can also see dysplasia and colorectal cancer. That's why we're doing every 8 years, we're going to do annual colonoscopies. That's what I was missing up here. Oh, yeah. Oh, no, actually, I have it up here. Annual colonoscopies 8 years after diagnosis of pancolitis with ulcerative colitis, because we want to look for dysplasia and colorectal cancer. Okay. Ulcerative colitis can progress to primary sclerosing cholangitis, which we learned about in the last exam. For Crohn's, surgery is not curative here, so definitely know that. Now, we kind of glossed over these in class, but this is actually pretty big. So eye issues, so uveitis, iritis, and episcleritis are indicative of or associated with inflammatory bowel disease in general. I don't believe it's a specific side here. It's in general. So definitely know that. Okay. More meds. All right. So there are meds for IBD. Let's just go through them real quick. So there's two classes. There's the 5 ASAs. So the 5 amino salicylic acids. There's not 5 of them. It's just what they're called. We have sulfasalazine, which is a zolfidine. This is going to be best for ulcerative colitis. Okay. Now, what's important here, this is a prodrug, so it doesn't do anything as is, but once it's split into something called sulfapyridine, that's what causes our side effects here. So we're going to look out for decreased male-fertility. That's huge, especially because ulcerative colitis is more common in men. We're going to see low white blood cells with leukopenia. We're going to see pancreatitis, and we're going to see liver injury. A big thing for this, if you do have a female with ulcerative colitis and you're putting her on sulfasalazine, you want to give her a folic acid supplement. I think you could give anybody this because they're going to be deficient in it, but you're going to get birth defects like neural tube defects if you don't have a lot of folic acid. Very important, definitely a question for sulfasalazine. Okay. All right. And I guess specifically, I don't know if that's for sulfasalazine in general or the sulfapyridine that's split. I don't think it really matters for that. Okay, then we can do mesalamine, and there's two different routes. We can do oral. That's our Asacol, our Lialda, and our Aprizo. These are mesalamine orals. Side effects here also pancreatitis, but now we're getting nephrotoxicity and renal failure as well. We can do mesalamine as a suppository. So it can be provided what they call technically topically, but right up into the rectum. And that's Canasa and Roasa. How you're going to remember the difference between the orals and the suppositories, it's like a can, like a big can of like string beans or something, and a rowing oar just right up your rectum. Okay. So Canasa actually sounds exactly like there you go. Canasa and Roasa are your mesalamine suppositories. Done. Okay. You can also give steroids, but not for maintenance. These are just good to like induce remissions. You're going to give these for flare-ups. Do not put them on these long-term. Prednisone, a lot of side effects here. I mean, it's a steroid, so it's insomnia, mood swings, acne, headaches, weight gain. It's like everything you see in like puberty, right? You want to also make sure you taper those down because they can cause adrenal issues, adrenal insufficiencies. Prolonged use for this, cataracts, osteoporosis, and avascular necrosis. Definitely going to be a question on that. So the prednisone, which is a corticosteroid, which we're giving for inflammatory bowel disease, watch out for cataracts, osteoporosis, and avascular necrosis. Okay. Budesonide is another one here. Fewer side effects when compared to prednisone. This is actually first line for a flare-up. I should have put it first here. Just know, I don't know, prednisone, like a predator, negative connotation, more side effects. Budesonide is going to be better. All right, let's talk about colon polyps and colorectal cancer. We are almost done, I promise. Okay, colorectal cancer screening, couple of different options. Fecal occult blood test. This is it guaiac based? It measures heme. That's why I have it red here. It can be affected by diet, like red meat, horseradish, and even aspirin or NSAIDs. And it can detect bleeding from the entire GI tract, and you want to run this annually if you're looking for colorectal cancer. Now, so that's an FOBT, a fecal occult blood testing. Now, fecal immunochemical testing, a FIT test, this measures globin and specifically from humans. So if you have like a bloody steak, it's not going to pick that up. It's just looking for the globin from human, from yourself. There's no, and it says right there, no dietary modifications needed. It is going to be more specific for a lower GI bleed. You're also going to run it annually. This, along with a colonoscopy for somebody who's like not super high risk, this along with a colonoscopy is like your gold standard for screening. Okay. Then there's this thing called the stool DNA testing. If you're looking for large polyps, you can run this. It's called Cologuard. So if you're looking for high grade adenomatous polyps or colonic malignancies, you can run the stool DNA testing. Okay. Yeah, so I do have this with like Fallout Boy, full of men. So FOB, men. He for heme, like they're full of he's. He is, male. That's going to look for heme. So FOB, heme. And then CrossFit across the globe. So fit and globin is what it's going to be testing there. Okay. It's also the gold standard. So go for the gold in your CrossFit. Okay. Then there's 3 visual things we can do to screen and to look for like polyps and colon cancer. One is a virtual colonography. This one is cool because I think it's like quick, and I don't believe they need to be sedated for this. Don't quote me on that. But we do have to follow up with a colonoscopy if it's abnormal. Okay. Now, flexible sigmoidoscopy versus colonoscopy. This is a huge one. Flexible sigmoidoscopy, it's great because you can perform it without sedation. Yes, yeah, perform without sedation, so you don't need a ride to go home after this. but it's limited. It can only visualize the colon for up to 60 centimeters. And the cancer polyp detection obviously is only good for this area. So if it's a right-sided issue, yes, if it's a right-sided issue, they're not really going to be able to look at that. Oh, it says it right there. They're not going to be able to look at it. You can run this every 5 years. Oh, wait a minute. I don't think that's right. Hold on. I got to check something real quick. Six. That is correct. Okay. Yeah. So a flexible sigmoidoscopy you run every 5 years or every 10 years if you're doing it with a FIT test as well. Okay. All right, there you go. Now, a colonoscopy, this is the gold standard with a FIT test. This is the gold standard to do with a FIT test. The drawback here is the need for a good bowel prep. So they have to like prepare the day before. They have to, drink laxatives and clear everything out. And you need anesthesia and transportation for that as well. Yeah, you can use, you don't want to have any red or purple liquids. I hope this is still recording. I'm looking up, there's a lot of stuff with the screening here. Yeah, so if you're high risk because you have family history, which is like a first degree relative before age 60 or 2 or more second degree relatives, start screening at age 40 or 10 years before the youngest colorectal cancer diagnosis. You do it every 5 years and you just do a colonoscopy. So that I think is important. Colonoscopy is the only recommended screening test for high risk. Okay, we're back. All right, so colon polyps, there's 4 flavors here. They spell Shia. So it's serrated, hematematous, inflammatory, and adenomatous. I know I'm saying those wrong. If it's this hamarto, it's got these weird names. It's juvenile polyps or Peutz Jeghers. So if it has a strange name, it's going to be that one. The adeno ones here, these are the most important because these are the cancer causing. So you're going to describe these based on their gross appearance, their histology, and their dysplasia, okay? These are going to be more common in men, and also you're going to see this more commonly in the African-American population as well. They have a higher risk of right-sided colonic adenomas. You're going to start screening them at 45. Big risk factors here are lifestyle. I didn't list them all out. It's like all the usual stuff. It's like, obesity, lack of exercise, smoking, older age, and male sex as well. So with these adeno polyps, which carry a cancer risk, you want to look at if you have a sessile or flat-based polyp, they produce the most cancer. So they cess out the most cancer. On histology, if you see the appearance of villous cells, vil like villain, so cess and villous, sessile and villous, this is really bad. They're going to carry the highest cancer risk of these adenomatous polyps. Okay. So we have to visualize the entire colon because in 1/3 of cases, if you have one of these, you have multiple. We want to repeat the colonoscopy every 3 to 5 years because the polyps are thought to require greater than 5 years of growth before being clinically significant. Okay. Now there's a couple of genetic things here. So familial adenomatous polyposis, FAP, That's a thing, right? It's autosomal dominant. It's rare in general, but if you have it, cancer occurs in 90% of untreated people by 45. That's crazy. You're going to see innumerable colonic polyps in childhood. I think the picture she showed us had like 100 of them. So you want to screen this young in ages 10 to 12. You want to do a yearly flex sigmoidoscopy. Remember, no sedation there, so it's going to be pretty safe for a kid. But once you see polyps, you then have to transition to yearly colonoscopies. If you have FAP, eventually you are going to need a total colectomy. So the whole colon has to come out. You can reduce the number and size of polyps with celecoxib, which is Celebrex. This is a selective COX-2 inhibitor. So it's going to inhibit your like inflammatory prostaglandins, but it's going to leave your GI prostaglandins alone. So it's not going to cause like ulcers or anything. Okay, Lynch syndrome is the other one. This is also autosomal dominant. It's also called hereditary non-polyposis colorectal cancer. Early age here at 48 with a predominance of right-sided lesions. Now, they're going to be using the Amsterdam 2 criteria. So remember, Amsterdam and Lynch syndrome go together. I don't know, think about like a linchpin in like a war or something, and like World War II was like fought over there. I don't know. I'm running out of ideas. It's been a long semester. All right. So you need all of these to suspect in your patient. It's the 3-2-1 of Lynch syndrome and the Amsterdam criteria. 3 affected members in your family. Okay. 2 generations, and one of them has to be under the age of 50. So 3 affected members with Lynch syndrome, 2 generations, and one of them under 50. There you go. Okay. Colorectal cancer, right versus left. So I made this chart anatomically correct. So right is going to be on the left here. So you're going to see liquid stool. You're going to see ulcers, chronic insidious blood loss on the right side. And you're going to get fatigue, palpitations, and iron deficiency anemia. That's a big one. So right side, iron deficiency anemia. When you go mini golfing, because remember, iron deficiency is microcytic, you're right-handed and you're going to swing that golf club. So iron, right-handed, right colon. If it's on the left side, these are more likely to cause an obstruction because the colon gets narrower as it goes more distally. And big buzzword. So an apple core lesion on a radiograph is going to be indicative of a left-sided presentation of colorectal cancer. Definitely going to be a question. Okay, staging of colorectal cancer. We use the TNM system. T is tumor, so the depth of it. A T3 is going to penetrate through the muscularis. N is lymph node involvement. And I think with this one, is it, are they contralateral or ipsilateral? Don't quote me on that, but it's, what lymph nodes are involved here? Are any at all? And are they, whatever. I'm not going to talk about that more if I don't know what it is. And then M is just going to be absent or distant metastasis. So are there mets somewhere? Oh, here's another exam question. We're going to do so great. So there's a metastasis of colorectal cancer. It's most commonly to the liver because of the portal system. Remember, the portal vein is draining the entire GI system because all of the nutrition and everything we're getting from the large intestine is going into the portal vein, and then it's going into the liver to be processed. Liver gets first dibs on all of that. So portal system, most common. Well, I'm sorry, the liver is going to be the most common area to get the metastasis from colorectal cancer, but it's using the portal system to get to there. Oh my gosh, there's one more PowerPoint. I thought I was done. All right, so anorectal disorders. This is not a long one. Let's kind of fly through this. All right, so hemorrhoids, if they're external, they're located distal to the dentate line. If they're internal, they're located proximal to the dentate line. Risk factors, anything that causes intra-abdominal pressure. So pregnancy, prolonged straining, constipation, ascites. And then you have advanced age because the elderly are going to lose support for their muscles. And then prolonged sitting or standing. So you can't really win there. So external versus internal. So external are going to be painful when they're thrombosed. So if they're on the outside, they're going to be painful. If they're internal, they're just kind of chilling in there. They're going to be painless. They're covered by rectal mucosa, the columnar epithelium. They're kind of chilling. External are going to be covered by a modified squamous epithelium. So squamous is thinner, and they're going to be painful because they're thin. Columnar are thicker, so it's going to be painless on the internal side. Internal, we can treat via banding, and these are graded. So if it's a grade 1, they bleed, but they don't protrude. If it's 2, they protrude with defecation, but then they go back after you're done. And if it's a grade 3, they protrude, but they must be manually reduced. 4, permanently prolapsed. So remember, 2 is that, I'm sure there can be some blood there too, but it comes out and it goes back in. 3, we need to put it back in ourselves. And 4 is it's out, it's prolapsed all the time. Both of these not left and right, external and internal hemorrhoids are associated with purtis, bleeding, bright red blood, usually coats the stool at the end of defecation, or it drips into the toilet like afterward. That's that question we were talking about, like, is the blood in your stool or is it on your stool? So this, you're going to see it on your stool. Treating this, use your bidets, encourage hydration. You can use hydrocortisone cream or suppositories or analgesic creams, but don't use them greater than 1 week. The hydrocortisone is going to risk mucosal atrophy, right? The steroid is just going to like eat away your mucosal layers. And then the analgesic is going to give you contact dermatitis. Don't use either of those greater than a week. If it's a week and you're still having these issues, it's, something else is going on. So just don't do that. And then a warm sitz baths. It's a warm bath you sit in. Okay. Remember, banding is only used for internal hemorrhoids. So if we have to go in to get it, we're going to band it while we're in there. Okay. All right. Anal fissures. These are a tear in the anal mucosa distal to the dentate line. You can actually see these in infants, but also in middle ages. And primary cause is local trauma. So passing a hard stool, prolonged diarrhea, vaginal delivery, anal intercourse. Secondary causes. Crohn's. I would have thought this would have been ulcerative colitis because Crohn's is more in the ileum. But I guess not. Maybe this probably has something to do with Crohn's being transmural, I would guess. So if you have a skip lesion down in the more distal bowel, you'll get an anal fissure. That's my hypothesis. Cutaneous TB, that sounds very buzzwordy for this as well, for these anal fissures. Okay, STDs and malignancy. They're most commonly seen at the posterior midline because it receives less blood flow compared to other areas, so less collateral blood flow, so right in the middle there. The hallmark of an anal fissure is simply pain. And what does an anal fissure look like? A paper cut. So anal fissure, paper cut. There you go. That's like one place you don't want to get a paper cut. So that's an easy way to remember that. How are we going to treat it? Supportive stuff, fiber, hydration. We can do a sitz bath, and we can use a topical analgesic like lidocaine. Probably don't want to use it longer than a week. These are kind of big. We can also use topical vasodilators. So nifedipine, that's a calcium channel blocker. We can use it topically to vasodilate and help maintain an atraumatic passage. You can use nitroglycerin as well. But again, these are topical. Totally a question here. If fissures are deep or associated with bruising, you should consider trauma or abuse in your differential. Anal abscesses. These are an acute manifestation of purulent material, usually coming from glandular crypts. So the crypt gland is blocked and allows for bacterial growth. Do we remember which of the inflammatory bowel diseases has to do with crypt? I think, was it crypt hyperplasia? I don't even remember. I just know it had the word crypt in it, and it's on the left, so it's ulcerative colitis. Okay, so it's crypt destructive colitis, but that goes with ulcerative colitis. So there we go. So this is not related. It's just using the word crypt as well. So it made me think of that. So the crypt gland, it's blocked and allows for bacterial growth. So you're going to get this abscess. To manage this, surgical drainage is going to be the big thing. You can diagnose this with a physical and history. You can do a culture if you're going to run antibiotics, or if they've been on antibiotics in the past and you think they have C. diff, which medication would you give them if they had C. diff? You can give them either vancomycin or you can give them Difficid. Vancomycin, remember, you want to give oral because IV does not cross into the bowel. And you don't want to mix it with those glycopeptides like tobramycin and those other ones, because it's going to cause red man syndrome. Okay. Antibiotics here for anal abscess is the same as uncomplicated diverticulitis. So that's going to be flagship. So that's Flagyl and Cipro. And then remember, Augmentin's an option as well. So same things here. So flagship with diverticulitis and the anal abscess. Just, I don't know, just remember that. An anal fistula is a thing. This is a chronic manifestation of an acute process that formed an abscess. So an anal abscess can progress into an anal fistula. Crohn's here again is going to cause an anal fistula. Radiation, obstetric trauma. You can see excoriated perianal skin. And the imaging here is aptly named a fistulography, or you can do a CT, or you can do an MRI. Oh my gosh. All right, there's one more page. This is like never ending. All right, incontinence. This is what they added to the blueprint this year. So we should really know it. So incontinence, there's two types. It's anal incontinence or it's fecal incontinence. With anal, you're going to see solid or liquid feces or just flatus. And fecal, you're going to see urge incontinence and passive incontinence. Interesting. Okay, interesting risk factors: diabetes, hormonal therapy, spinal cord injury. Remember, the internal anal sphincter is contracted at rest and provides 85% of the resting pressure. That kind of makes sense. If that was open, it would go to the external anal sphincter, like, the fecal matter would be sitting too low. And it's the external anal sphincter and the puborectalis, which goes around it, that are under voluntary control, and they're working together to provide additional tone. Causes of incontinence, you should probably know these. It's anal sphincter weakness, which can either be traumatic or atraumatic. The big thing here also is childbirth associated with forceps delivery. So that's going to be anal sphincter weakness. So childbirth with forceps delivery. It can also, so decreased sensation is another one, like with diabetes, like with neuropathy, and you're just not feeling things. Parkinson's, spinal cord injury, so other things, other causes of like sensory loss. You just don't have the awareness to defecate, and it just kind of comes out. Decreased rectal compliance, our rectum is just small and can't store volume. Or overflow diarrhea. This is where you have like a fecal impaction, and it inhibits the internal anal sphincter tone, the one that's normally constricted. So it's kind of, I believe it's stuck open, and then liquid stool just like comes around the fecal impaction. So the diarrhea, it overflows. So an anal wink reflex is a thing that you can check. You can do a fiber supplement. So you can do loperamide, Imodium, or cholestyramine, Questran. I'll go back and go through these mnemonics because I kind of glossed over those, but I have that quill mnemonic. So Questran and Imodium, these are going to be in the IBS-D category. All right. What's not going to be here is Lomotil, so that's not listed here. But Questran, which is the bile acid sequester, and Imodium, which is going to be that opioid agonist, can be used for, what are we even talking about? Incontinence, right? Yeah, okay. So that makes sense. If we're using it for diarrhea, we kind of want to give more, bulk to things, give things more transit, especially if we're fixing like this overflow diarrhea, kind of reversing that makes sense. And then we can consider a referral to something special called a pelvic floor physical therapist. Okay. Let's go back up to these meds real quick for like irritable bowel syndrome, because I did have some mnemonics for that. Where even was that? Oh, I just had it. Okay. So I did talk about, for stool softeners, it's like a soft piece of lace over your anal fissures and hemorrhoids. So that's going to be your docusate, your co-lace. So lace over your anal fissures and hemorrhoids. Okay. This one here I have for osmotic laxatives. There was a movie back in like the 2000s called Osmosis Jones. So think about spilling milk on your PG magazine about Osmosis Jones. So this is your milk of magnesia and just, anything with magnesium. So the magnesium citrate is there as well. PG is polyethylene glycol, which is Miralax, and then lactulose. So it's like a double milk thing. You're spilling milk. So lactulose and milk of magnesia. Remember, these are hypertonic and they're osmotically active that draw water into the colon. I have this one here for Pamoras. So it's like you just moved into a neighborhood full of opioid users. So you want to relist and you want to move ant. So that's me. So relist is relistor. And then move ant is Movantic. So these are the reason opioid is in here because they're the opioid receptor antagonists. And these are used for opioid-induced constipation. For our IBS-Cs in the bottom left here, these spell malt. So think of like a thick malt milkshake making you constipated, like a really thick malt milkshake. So you have Motegrity, Amitiza, Linzess, and Trulance. So I have here, you're constipated in a motel in the AM with Lindsay and your good buddy, Trulance. So motel is going to be Motegrity. Oh, AM in the morning is going to be Amitiza. Lindsay is going to be Linzess. And then Trulance, your good buddy Trulance is Trulance. And just remember, those are ordered in a very specific order. The first one is the simplest. It's just for chronic idiopathic constipation. The final three are for CIC and IBS-C. But the second one, that Amitiza, it has to do with chloride channel activation. So it increases salt and water in lumen. That's the one that's just for women over 18. Okay. I think it's just for women with 18 with IBS-C and also those with CIC. I think that's what it is. And then the final two, Linzess and Trulance, those are going to be the guanylate cyclase C agonists. Okay, so let's just do antibiotics and then we'll be done because I do have this up here and we can kind of talk about antibiotics individually, which I think is important versus just looking at them with their diseases. Okay, so let's talk about beta-lactams and cephalosporins. They're both on the upper right here. They're both similar. So they both inhibit cell wall synthesis because, again, a cephalosporin is just a synthetic beta-lactam. Beta-lactams, for the most part, are going to end in psilin. They can cause diarrhea. So we talked about amoxicillin and ampicillin causing diarrhea. Cephalosporins are also going to cause diarrhea, just like the whole class, okay? Now, because of these are on the right side, on the top, and then also the bottom, they're going to cause C. diff. So cephalosporins, beta-lactams can cause C. diff. Let's talk about ampicillin. It covers gram-positive and gram-negative. This is our first line for listeria. Remember, we were talking about those women with their shopping list, and they're like all amped up. It was women because listeria and pregnancy causes that like flu-like symptoms. All right. Ampicillin can also cause rash, diarrhea, and nausea. Cephalosporins, we talked about cefazolin, which is Ancef. That's that first gen. Remember, we talked about this with the flagon mnemonic, which is for appendicitis. And there you go. So it's first line for uncomplicated appendicitis. Despite it being a first gen, it actually does cover gram-positive and gram-negative. Okay. Ceftriaxone, Rocephin, ROC. We mentioned this with ROC, flag, and eagle. So this was part of the treatment for ROC, flag, and eagle was complicated diverticulitis along with flag, which is Flagyl. Okay. And then eagle were Zosyn and Unison. I remember this stuff. I hope you guys do too. So this is our first line for uncomplicated. I'm sorry, we already talked about Ancef. First line for uncomplicated appendicitis with Flagyl, the flagon. Okay, I'm sorry. Yeah, ceftriaxone, Rocephin. It's that complicated diverticulitis with Flagyl. That's our ROC, flag, and eagle. And it can cause biliary sludge and colic. How I think of this too is like ROC for Rocephin is ROC like a gallstone. So biliary sludge is a precursor to cholelithiasis. So that just works. Okay, let's move down to, I guess we'll just go in order. So metronidazole, this is Flagyl. This is the one that's absorbed by anaerobic bacteria and protozoa, broken down, and then kills the bacteria. That's like so metal that it does that. It just sneaks in, breaks down, and then kills the bacteria. It's so metal, in fact, that it tastes metallic. So there you go. It's used for Giardia. Okay, remember that Alina who was waving the flag for Giardia, because Alenia is the other med we can give for this, and it's flag because she's in the colored guard, so Giardia. It's also first line for uncomplicated appendicitis with cefazolin and cef. So that's, again, the second part of the flagon mnemonic. That was that like old-timey 1876 surgeon with the flagon doing his first, appendectomy. Flagell is also that first line for diverticulitis with Cipro, and that's going to be, because this is flagship. So I'm going to specify that and say uncomplicated. And make sure Cipro, we have the same. First line for, I'm going to say uncomplicated diverticulitis. Make sure we're very clear here. Okay. Metronidazole cautions. It's that antabuse reaction with alcohol. Don't mix it with alcohol, and it has that metallic taste. There was an exam question that I got wrong, and it said something about like 1 month after taking metronidazole that you can't drink alcohol, which isn't true because you're not taking the antibiotic anymore. So I guess as soon as you're done taking it, you can just like go on a bender. So just know that you don't want to take it with alcohol at the same time. So if you're done taking it, go crazy, I guess. But it does have a metallic taste, which is totally benign, by the way. Okay, glycopeptides. There's just one we talked about. It's vancomycin. This also inhibits cell wall synthesis. All right, so you can think it's right below beta-lactam here. It's going to inhibit cell wall synthesis. It covers just gram-positive. That's huge here. It's also first line for C. diff. If you remember, we want to give this oral, not IV, or we can use fidaxomicin, which is Difficid, which I don't have on this chart. So just remember that. Okay, we had those cautions with vancomycin. Again, we don't want to combine them with Genta, Tobra, or streptomycins, which are those aminoglycosides. I may have said those were glycopeptides earlier. They're not. They're aminoglycosides. They're aminos. Okay, this can cause autonephrotoxicity if combined with them. And again, IV Vanco, which we don't want to give, we want to make sure this is oral. I'll just put oral here. It can be given IV like for other stuff, but you don't want to give it IV because it can cause red man syndrome. Okay, let's talk about the combos. So we have piperacillin, tazobactam, Zosyn. Every combo here, Zosyn, Unison, Augmentin, they cover everything. They do gram-pos, gram-negative, aerobes, and they do anaerobes. So they cover everything. Okay, piperacillin, tazobactam. This is Zosyn. We're going to use this for severe, complicated appendicitis. All right, so after flagon, if that doesn't work, then we're donezo, right? We come in with the Zosyn and we're donezo. We're also going to use this for complicated diverticulitis. This is part of rock, flag, and eagle. Ampicillin, sulbactam, also part of rock, flag, and eagle. And again, that eagle part was we're going to sin and we're going to spend a bunch of money. So you pull in your sins. You pull in your Zosyn and your Unison. That's for complicated diverticulitis. And I have a thing here. You're using them. That's a sin. They are expensive, whatever. Amoxicillin, clav, Augmentin. So again, covers gram-pos, gram-neg, and anaerobes. This is second line for diverticulitis. For uncomplicated diverticulitis, if flagship, Flagyl Cipro, does not work, then we can use Augment. I don't think it's not that it doesn't work, but you can also use Augmentin, okay? Big caution with Augmentin, look out for hepatic dysfunction. All right, the sulfonamides, these interfere with folic acid production. Bactrim is the one that we talked about. And this is, Bactrim is, it's worth like just knowing this exists. Trimethoprim sulfamethoxazole. I think they just call it like TMP or TMS or something. But that's what that is. And we use that for Yersinia enterocolytica, specifically for peds. Okay, move on to the macrolides. These inhibit protein synthesis. We're going to have azithromycin, which is our first line. Remember, you pop your zits before you travel for traveler's diarrhea. It's going to be our second line for salmonella. Oh, I do have fidaxomicin on here, deficit, because it is a macrolide. So this is first line for C. diff, or we can use vancomycin. Remember, they're both technically first line, I believe. Clindamycin is on here just because it can cause C. diff, so just remember that. All right, last but certainly not least are our fluoroquinolones. These inhibit DNA replication. This, as well as macrolides, specifically clindamycin, cause C. diff. So again, the bottom two right and the upper two right. All right, they can be impaired by antacids. General fluoroquinolone cautions: tendon rupture, we have peripheral neuropathy, QT prolongation, CNS toxicity, and warfarin interaction. I don't believe those last three were mentioned in this class, but we need to know them anyway for the final, so there they are. We don't want to use fluoroquinolones in kids due to articular cartilage damage or arthropathy. We want to avoid in those over 60 or those taking corticosteroids. Again, these can cause tendon rupture as well. We also want to avoid this in patients with myasthenia gravis because this makes muscle weakness worse. Okay, ciprofloxacin specifically, great gram-negative coverage. That's usually the case for fluoroquinolones. Moderate against gram-positive, okay? It's going to be our first line for salmonella. And it's our first line for uncomplicated diverticulitis with flagell. Ciprofloxacin cautions. You want to take Cipro 2 to 4 hours before any antacids. Antacids can inhibit the effect of this. Tendon rupture, we said this already, especially greater than 60 patients. And I don't think it's if they're on corticosteroids. I think it's or a patient is taking them. But both are bad, and you want to avoid in myasthenia gravis. Last thing, levofloxacin. That's Levaquin. It covers enteric gram-negatives, and that is our first line for salmonella, I believe, with Cipro as well. So I should have put an or there, but you can use either. Okay, that's it. That's all I have. I have no idea how long I've been doing this, but I will upload this. Good luck with finals, and I will see you in the next one.